at Gitanjali Medical College and Hospital, Udaipur. First of all, I would like to thank Dr. Sushma ma'am, Anju ma'am and team for giving me this opportunity to be a part of this great conference and to moderate this very
Seema, you muted yourself.
Am I audible, ma'am?
Yes.
Yeah, so I'm going to moderate this very important session, leadership in palliative care. Leadership in palliative care is very needed, very much essential to bring this specialty in forefront of the healthcare system. A good leader, as we all know, this palliative care team is a multidisciplinary team, and a good team leader creates a mission and vision in every team member. He motivates every team member, rather he creates a leader in every team member to provide effective and sustainable palliative care services. So this session is going to be very, very important for all of us, like the beginners like us. And for this, to chair this session, I invite Dr. Seema Mishra ma'am. Dr. Seema Mishra ma'am is professor in Department of Onco-Anesthesia and Palliative Medicine at AIIMS Delhi. She has done fellowship in palliative care from various institutes of USA and UK, and she has experience of over more than 2 decades in palliative care services. She has been awarded the Royal College of Physical Travel Scholarship and Commonwealth Scholarship as well. She is national faculty member of IAPC certificate course since 2009. She has around 200 publications in various national and international journals. So I request Dr. Seema Mishra ma'am to please introduce the esteemed speakers of this session today. Thank you, ma'am. Dr. Seema Mishra ma'am, please.
Thank you, Dr. Seema. And as we suggest, the session is effective leadership in palliative care. And we have 2 eminent speakers, Dr. Fiona Rawalson and Dr. Priyadarshini Kulkarni. And Dr. Fiona Rawalson is Director, Cardiff Development Alumni Relations Department since 2015 and serves on the University of Executive Board. She is a fundraising and alumni relations professional. She has led Cardiff Development and Alumni Relations Department since 2015 and serves on the University of Executive Board. She is a former Director of Development University of Bristol since 2003 to 2015 and Development Director, University of College, Oxford in 1998, 2003 and Development Director, English National Opera in 1996 to 1998. Currently, she is volunteering Trustee of Arts and Business 2019 at present and Case Europe Council member, Editorial Board of Case Ross Survey and lead volunteer since 2004. And she is going to present need for leadership in palliative care. And Dr. Priyadarshini Kulkarni, she is going to speak on the teamwork and the leadership. She is the Medical Director, Cipla Palliative Care and Training Center, Pune, India. She heads a team of doctors, nurses, medical social workers, and volunteers that provides holistic palliative care to cancer patients and free of cost. And she has initiated various training programs at the Center for Professionals from various walks of life, including new members of the team, especially in the areas of pain and symptom management. Let us now hear from first speaker, Dr. Fiona Rawalson. She is going to speak need for leadership in palliative care. Dr. Fiona.
Hello, everybody. I'm honoured and delighted to be part of the conference this year, and I'm excited to be able to spend just a few moments really talking about the need for leadership in palliative care. My background is from Wales, from Cardiff University, and as a clinical consultant in the community in Cardiff. One of the things that it's useful to think about when you're thinking about leadership in palliative care is, will this apply to me? But it's also important to think about the overall picture of palliative care. So what we're going to think about is the need for leadership, what the role is of a leader, and perhaps one or two strategies that might be useful as you consider your own leadership skills or consider them for the future when you might develop leadership skills. From Cardiff University, we've got a particular communication framework, the 6-point toolkit, that was designed for patient and family conversations, but in fact, it's an extremely useful toolkit for communication in teams and in leadership positions. So as we start, perhaps just take a moment just to think about your own personal leadership experience so far, wherever you work, whatever discipline you work in, whatever role you've got. You may feel you're not in a leadership role at the moment, but are working alongside a leader. When you become more senior, more advanced in your role, what sort of leader do you want to be? We can spend a lot of time working up to leadership, but actually when we get there, you suddenly realize that there are responsibilities that you're not quite sure about. So I think focusing on palliative care, focusing on what it is we need to do is important. Sometimes it's worthwhile taking a few minutes out to think, actually, what do I think makes an effective leader? Is it somebody who's a very strong personality? Is it somebody who gets things done? Is it somebody who's a good communicator? So it's worthwhile spending a few moments thinking about that. But it's also worthwhile thinking about the role of leadership in palliative care as a discipline. There is so much work that we all have to do to get that palliative care message out there and to look after our patients and our families who need us. This sort of data on this slide is going to be familiar to many, many people. We know that the global need for palliative care before the pandemic was great. We know that in some parts of the world, particularly lower middle income countries, there is a lot of inequity. There is a lot of difficulty accessing palliative care. There are simply not enough healthcare professionals that have got any palliative care experience or who understand what the palliative care experience needs to be. So if palliative care is the thing that interests you, every time you encounter another healthcare professional, there is a need to talk about palliative care. The numbers needing palliative care, of course, will have gone up as a result of the global coronavirus pandemic. And there is a lot of data out there around the palliative care needs in different parts of the world. So, leadership in palliative care seems to be a very big subject, doesn't it? Actually, what does a leader in palliative care need to do? Why is it so important? If you think of the overall, the global context, what does palliative care need to do? It's improving the quality of life of patients with life-limiting illness. They're generating an evidence base. So the need for leadership in palliative care is to help coordinate evidence-based, high-quality palliative care. We need to engender trust from the patient and family and other healthcare professionals. Many people still do not know what palliative care is or think they know what palliative care is, but they might be wrong. We're not just end-of-life care. It's not about euthanasia. It's about quality of life right up until that last moment. Why else do we need leadership in palliative care? We need to raise the profile for the discipline in all areas of healthcare and care to get that best quality of care for the patient. To do this, in an ideal world, we need to collect teams around leaders in palliative care. And they can be sometimes surprising, unexpected team members. It's very often in developing services, one can feel very isolated. If you are the person that is going to take the lead in the service where you are, and you're going to develop it into something, you can look around and think, there's nobody else who does what I do. But actually, educate, gain support, collaborate, work alongside other people. And in that way, you will coordinate, collaborate, and develop the team. But of course, as the public health model for palliative care shows, as I will go on to in a moment, the need for developing that profile of palliative care, so that implementing palliative care becomes less of a challenge. It just becomes part of general health government policy. We need people who can do that. So we need leaders in palliative care. We need the teams around the leaders. Anything we develop needs to have that longevity behind it. It needs to be sustainable. And if you think about the public health model, the Jan Stjernwald model that on the WHO, the World Health Organization, continues to feel is the best evidence-based model for developing palliative care services globally, there is information around policy that needs to get out there. Palliative care as part of the National Health Plan, opioid availability, perhaps certification to enable opioid prescriptions, essential medicines, funding, service delivery models, all around the evidence base. So there's a policy bit, there is drug availability central to effective palliative care, particularly, of course, around opioids, opioid availability, generating the opioids, prescribing them, distributing them, storing them, accurate implementation, involving all sorts of people. So the pharmacists, the drug regulators, the law, legal aspects. So drug availability is a big part of palliative care. Implementation of all of these, we need to train the manpower. You need to have a strategic, a business head, a business model. How do I know that the palliative care service that I am going to develop in my part of the world, how will I know if we do a good job? How will I know what difference do we make? How am I going to find that out? Who do I need around me to help generate that information? And this is the same wherever we work across the world. Successful implementation, successful development of sustainable services needs all of these aspects. There is, of course, the clinical skill. People need to be able to deliver palliative care, to demonstrate what it is that they're doing so that others can learn. And that then brings me on to education, whether it's education of healthcare professionals, whether it be care workers or nurses or social workers or therapists. There's education of the media, of our communities, of general population, but ensuring that the right messages get out there. It's absolutely imperative that we try and address any of the inequities, that we try and address any misinformation that is out there about what palliative care is. Because palliative care patients need us. They need our skills to make the quality of their life as their life is ending as best as it possibly can. And of course, round a patient is a family or a collection of caregivers. Families are still very dispersed, and as a result of the virus, I think will remain dispersed for a while. Families have lost family members because of the virus. So the people on the ground to help care for that patient may be less than they were, and they definitely need support. They need support, they need education, they need training. There is training of the specialists. There are training of people who want to make palliative care their discipline. All of these need a coordinated effort. They need somebody to have that overall view of, in that region, what's going on. Collect regions together. Is there an overall leader for that collection of regions? And then, of course, at a national level. So there is a lot of work to do. And there's a lot of work to continue to do. One person can't do it on their own. They need teams around them, but teams need that leader with that overall vision. So what do you need to be able to do this? And I know that Dr. Priya Kulkarni is going to spend a little bit more time on this shortly. But I think to enable an effective leader, if you look at the global leaders in palliative care at the moment, one of the key features for everybody is very clear communication. And that's not only communication about the need for leadership in palliative care, but it's also communication within teams and within their own region. There are listening skills, being able to listen and bring together people's experience. But as well, there is such a lot of work to do that as a leader in palliative care, actually the need to be strategic, to prioritize what's the most important thing in my area and what can I do to start implementing, start developing, start sustaining, start supporting the services that need to happen. And it may be that there are 2 or 3 things that one feels is a high priority, but you need to be able to start in one direction and to bring other people along with you. So using SMART goals, using some basic project design will help create reasonable projects that have great chances of success. If in doubt, think small and achieve success, and then other things will follow as a result. And of course, being creative and using teams and resources. It's very easy in palliative care as it develops to feel that you are a lone leader, but actually there are people around you who you can call on. I think communication skills are central to this though. Just thinking globally of different countries of the world in the international perspective and matching that to what styles of leadership are needed for different situations. It's interesting. There are different sorts of leadership and there may be different situations as we develop our services in palliative care, but actually a slightly different style is useful. So if you observe a leader who has just one leadership style, they're probably very effective for 90% of the time, but there may be 1 or 2 things that just don't quite get done in the same way. So, for example, an autocratic leader has a process, it's followed, it's inflexible, things get done, but there's not room for creativity. So if things change, if the situation changes, if a global pandemic arrives, for example, that style of leadership might not work for some of the different tasks that have to be done. Palliative care is full of people who are hugely compassionate listeners and like to try and bring a team around them. And a democratic leadership is quite a flat style, where there's very much a team approach. It's 2-way communication. It's greatly collaborative. It's a wonderful sense of collaborative and team spirit. But just occasionally, there will be a complicated situation, a complicated decision that needs to be made. Something urgently has to be done. And actually, sometimes that democratic style, if it's used all the time, can be a little bit too slow. Transformational style of leadership is the one that I think many, many people aspire to, and it encourages activity and achievement. It sort of builds on a democratic process, really. But again, for the same reason, just occasionally, in some of the things in palliative care delivery, it may be a little bit slow. An example of that, for example, would be PPE at the start of the coronavirus pandemic. Now, I know this is a very conflicting topic because of the availability of PPE as things started. So you may not feel comfortable as I describe this situation, but in that situation, once we knew that personal protective equipment made a difference to the virus, as we worked, we needed to change how we worked. And actually in the UK at that point, it became a government mandate. And so we had to change the way that things worked. And so in that instance, actually we needed an autocratic, we needed a transactional style. We needed to say, team, this is what we have to do. This is why we have to do it. We're starting from now. So that's, again, just an illustration of sometimes that transformational style. You just need to become a little bit transactional, and the transactional style achieves things, but it's a little bit process followed still. It doesn't really encourage development of the team. You want your team to develop around you as a leader, that you will develop services, you can be flexible. If things change, you're going to be able to be up there with those changes, respond to changes in evidence. So a transactional style might not empower your team members in the same way. As leaders in palliative care, we need to grow the leaders of the future, because as a leader in palliative care, you won't be there forever. And so it's important that we share these things with our teams. The laissez-faire sense of leadership You stay working in the usual way. You don't really mind very much about what happens. It's comfortable. There's not very much conflict, but it's not necessarily going to respond to changes around you. It's not flexible enough as a style. Although when you start as a leader, or if you're suddenly thrust into that leadership role, sometimes actually there is a merit in not changing anything very much, just sitting. You're new to a service, you're new to a team, just observe, just listen, see what's going on, and then start to work with the team to make some changes. So going back to that communication, that thread of communication running through leadership, I'd just like to finish just by putting to you, and some of you will know about the Cardiff 6-point toolkit already, just putting to you that it's a very useful toolkit as a framework for leadership conversations. We need to think about the comfort of the people we're talking with as leaders, particularly if you're negotiating with people, you're trying to manage change. We need to check that people understand our language, whether it's our verbal language, our written language in emails asking people to come to meetings, in plans, in documents, our body language. So if you want to negotiate something and you have a very closed body language, it's unlikely to have that same result. It's just the same tools. The question style, if you want to explore things with people, open questions, hypothetical questions, very useful. Our listening skills. If somebody comes to you as a leader with a concern, you need to demonstrate that you've got active listening. Use those listening skills. Use the reflecting back of phrases. A team member comes and says, I'm really worried about how we're going to implement the new rules for opioid prescribing, or I'm really worried about this team member. And you can just reflect back the word worried. You're showing you're listening, you're engaging in that dialogue. And summarizing, vital skill for leadership, particularly after complicated meetings, after a complicated task, and you've delegated tasks to different people. Summarizing remains a core skill. So that Cardiff 6-point toolkit that was developed for patient and family communication is really useful in all conversations, and particularly in leadership. And if you want to use it as a reflective tool to reflect on your leadership conversations that you have, even team working conversations, just think about any of the aspects around the tools that have facilitated and that have been barriers. Try not to think about good and bad, because those are value judgment. Everybody has days when they're not quite working as well as they might want to. So facilitating and behaviors and facilitating tools, and tools that actually are not used particularly well. The tool is only as good and effective as the person that uses it. So as I say, it's a useful tool. Authenticity is at the key of it. You need, as a leader in palliative care, particularly when you're developing services in a new region, you need to walk the walk and talk the talk. Your behavior, your speech has to match up, and people then have much more chance of trusting you, of going with you, and communication will be straightforward. So it's rewarding, it's exciting, it's challenging, and it's really empowering for palliative care development. Challenges are many, which we will come on to in the second part of this session. But a book that I would recommend is Paul Lencioni's 5 Dysfunctions of a Team. And one of the aspects in palliative care is that we tend to be very good listeners. We tend to be very compassionate. We might tend to try to avoid conflict. And this is one of the 5 dysfunctions of a team, a fear of conflict. Conflict is not always bad. It sometimes will challenge how the processes have worked so far, but sometimes it can lead, if it's managed appropriately, it can lead to a much more fulfilling, a much better outcome. At the centre of our work as leaders in palliative care, in any aspect of palliative care, has to be the quality of palliative care that is delivered to our patients and our families. That has to be the core that we work. Leaders, we look after ourselves. we have to sometimes accept that how we want to do things may not be possible at that moment, but never lose hope. Just keep on using those professional development, those reflection skills, and sometimes unexpected things will happen. Know that if you're hungry, if you're angry, if you're late, if you're tired, if you're stressed, if your life is too busy, it's difficult sometimes to be objective. So you need to work out how you're going to do all of this. So leaders need teams, teams need leaders. I'd like you just to have a little think about your role in palliative care as I finish my section of this session, and just think about your reflections on leadership so far. And we look forward to having some discussion in the second part of the session. I'm going to pause there. Thank you so much for your time and listening, and hand over to my colleague, Dr. Priya Kulkarni.
Hello. Dr. Priya Darshini Kulkarni ma'am is consultant palliative medicine at Pune. She is founder of Ease and Support India. She had a chapter lead Elizabeth Kubler-Ross Foundation, and she is past secretary of Indian Association of Palliative Care, and she has been author of Touching Hearts Gently book. So I welcome Dr. Priya Darshini Kulkarni ma'am to deliver her talk.
Thank you.
Please.
Thank you. I think we are putting a recorded one.
Yes.
Good evening, everyone, and thank you, Dr. Fiona, for this wonderful presentation. I also would like to thank Dr. Anjum and IAPCON 2022 team for taking this topic, which is very, very important in palliative care development in India. Where we stand today, as we are training many people in various sectors of the country, I think it is important for us to know how the leadership can make a difference in development of palliative care and sustaining palliative care. Most of the things are covered by Dr. Fiona as a theoretical aspect. My task would be in next few minutes to tell you about how it practically helps us to have leadership in palliative care. So what I'm going to cover essentially is role of teamwork and leadership. So look at this picture. It's a group of two people and they are trying to achieve running towards the finish line. You can see these two girls very happily marching ahead. And the other two, which are on the ground, they couldn't complete the task. Look at these girls, which will tell us that they are working towards common goals using their complementary skills. Again, in this picture, all of them, they look so happy doing and completing this task of taking this rope on their side and achieving something together. Isn't it the teamwork? And we all know that we have been learning and utilizing teamwork since our childhood in various tasks. So what is leadership really? It is ability to influence others to work towards that common goal and transform a vision into reality. I'm showing this picture where you can see these little ones are trying to play music together, but all of them, they are looking at their teacher and following the lead from her, isn't it? So she is leading while they are following. So leader is that influencer which helps others to work towards that common goal. So coming to palliative care settings, our common and one goal is to reduce patient suffering and improve their quality of life at any stage of their disease, right? We use interdisciplinary skills for better understanding of their needs, and we try to give holistic care. So in general, in healthcare, we always work in a complex environment. There are many surprises. There is uncertainty many times. Many a times, especially when we get patients coming from faraway places, there is no complete information with us. Their documents are not there with them, and we have to depend on whatever information we can gather at that moment. There are many interruptions, and we have to, many a times, especially we all have seen in COVID times, we have to multitask. So when we are faced with this challenging situation, who takes that call? I remember my training days when we were trained by San Diego Hospice in leadership training. And the very first lecture we were taught that you are either a leader by position or you are a leader by permission. And what does that mean? Imagine one of you who are a part of team, one fine day, you have been given a task to lead the team when you are not ready really to take that leadership role. You have to have, in that case, by virtue of your position, you are expected to do effective decision making and problem solving, because that is going to help you improve your organization's goals. Or sometimes you are a leader by permission. You are part of the team, but whenever there is a problem, you choose to lead. And your actions enable others to act. So this picture kind of try to differentiate between who is a leader and who is a boss. And I think we need to understand the difference. If you see in this figure, the top portion, leader is leading the way. And where the boss is directing everyone to work in a specific function. As Dr. Fiona was explaining, there are various styles and no one style is right or wrong. But we need to understand what kind of a leader we want to be. So I am going to take two scenarios. One is home care and one is hospital-based teams. We all know that our teams in home care includes doctors, nurses, counselors, medical social workers, volunteers. But the most important is patient as well as family members. When we know that patient is at the center of whatever care, holistic care we are giving, I think family member as a team member plays a significant role as well. And there are benefits to family member being a part of the team, as well as there are benefits to the treating team, healthcare team as well. We all know that when faced with life-limiting illness, family members are stressed. They are emotionally stressed, physically stressed, and they need help. By being with patient, they are kind of socially isolated. And in some cases, they are burdened to look after their loved ones. They need support from our team in terms of getting the right information, counseling them, and giving practical assistance, sometimes in home settings, training them to look after their loved ones as well. But it helps our healthcare team as well. Palliative care team needs inputs from family members, especially when they are looking after the patient in home setting. They need insights from family member to know whether the disease is progressing. It will only be known to them when family members are describing the situation in home setting. We cannot be there 24/7, and we have to depend on family members for getting these inputs. It is helpful when families give us the clues about assessing the improvement in, for example, pain management. It also helps to improve quality of life of patient as well as family member, and I would go a step ahead and say healthcare teams quality as well as comfort of the team to look after patients when they are most of the time away from the patient. Our patients need emotional support 24 hours, and we cannot give it. We can be using this family member as our team member. So all this is happening is fine, and we need leadership for doing this. Or teams are working by themselves. There are certain situations when we really need this leadership skills. Imagine that you are short-staffed teams and there are 2 home calls, emergency calls at same time. You don't know where to go first because the other patient is going to be upset with you. Sometimes there are conflicts between patient and families, between treating team and family member. And who needs to take the call to lead all of them, get them together and lead them? Sometimes there are personal biases we need to look into. And sometimes we have to work around the resistance from the patient or the family member. I'm just putting this slide here and can be explained in little detail, but just looking at the time frame, I would like to say that, many a times once we decide that patient and family is a part of our team, there is a great role in home care settings as well as in hospital settings, a role for family meetings. It gives you opportunity for shared decision making, to have explained to them about available information, know their understanding, know their culture and background, and also understand the barriers. Once we know that, we can then decide how to negotiate with them. And this picture on left hand side is very important to know we as a leader, which is the circle of influence in that case scenario, and which is the circle of concerns. Once we know that, then we can able to negotiate to achieve the goal of patient care the way we want. Any team cannot happen in one day, and it goes through various phases. So in team's life cycle, there are these classical, 4 phases. First is a stage of forming, where, people from different disciplines, a doctor, a nurse, a social worker, a volunteer, they come together, they barely know each other. They barely know each other's strengths and weaknesses, but the intent is high. They want to work together. They form a team. When they start working, the conflict starts coming. Who takes that decision? That's the stage of storming. When they go through this phase, they slowly try to a stage of acceptance of who does what. They know whose role is doing what and where they should be keeping quiet. So they learn to work through their frustrations, and that's the stage of norming. And once they pass this stage of norming, then the stage of performing comes. that they know that, like in orchestra, they have to play their role to the best of their capacity in synchronous with others to have this effective team effort. So coming to hospital-based palliative care teams, we know that in many settings there are anesthesiologists who are leading the teams. Sometimes it's radiation oncologist or surgical oncologist or a palliative care physician. Who decides who leads the team? Is it the workload? Is it the pain management skill? Is it the turnover of patient which comes to them? And it's a challenging decision for a team to decide. So how in such cases we try and increase the effectivity of the team? We have to decide on a clear purpose. As Fiona explained it, we need to have a good communication, good coordination, and set protocols. We have to find effective mechanisms to find the resolving these conflicts. We need to have active participation from all the members. Sometimes if team members are not happy, they just try and do their work without putting their heart and soul into their role. And that affects the work of the team. We have to, therefore, as a leader in palliative care, you will have to promote individual development as well as teams' interdependence. We have to recognize and understand the benefits of working together while having that accountability and responsibility of doing best possible care possible for our patient and family. So leader in palliative care is a change agent. Who amongst all this? Everybody is doing their job. But the first one who's leading is guiding all others, and he is helping them to change what is needed for best possible results. So again, with having this clarity about who does what and what is the hierarchy, knowing defined boundaries and having this task dependent goals achieved, leadership can be effective. We have to remember that when we have a good leader and a good team, then only we can achieve better outcomes. And we know that together everyone achieves more to improve the quality of patient care, enhance patient safety, and reduce workload issues and even team burnout. So you as a leader, try and empower people, lead the change, inspire people, and share the vision. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. I leave it for you all to think about, are you already a leader? Do you want to be a leader? How will you become a leader? Who are your team members? I mean, not the persons, but who do you want to be in your team? What are their strengths, weaknesses, and what kind of a leader you want to be in? I stop here and I think we will now answer if you have queries together. Thank you.
Dr. Fiona and Dr. Priyadarshini, one by one, you can just give your insight.
Thank you so much, and again, thank you in person for inviting me to join Priya. We've had a number of conversations as we have developed the material for the session. I think a personal leadership journey often starts before you realise it, and I think as Dr. Priya was saying, sometimes you become a leader sort of by accident, because that is just that's just the circumstance at the time, and you begin. I think we are so busy getting on with the job. The patients and the families are our focus all the time, but you might suddenly realise that actually I've just organised this family meeting. I've just collected a team. I've just done this, that, or the other. And it isn't always about seniority. It isn't always about being the most experienced or the oldest member of the team. It might be about whether you're the person who's got the skills for the particular task in hand. So an example would be when I was working in a palliative care unit with a day hospice. We were very confused about what the role of a day hospice was in compared, for example, to outpatients. So why did we bring people together to spend time together instead of bringing them to a so many different people? And I had a particular interest in day hospice. And so I took the lead for that, but I wasn't the senior consultant and I wasn't the senior occupational therapist, but I had a lot of contacts. I had a lot of contacts in outpatients, and actually for that task, that was where that started. I think before I hand over to Dr. Priya, I think my personal journey of leadership has been one of moving from absolute compassion and understanding and team working. I love having a team around me. I love working as a team. Definitely together each achieves more, and it's fun. Even the bad times, you're together, you're doing something. And I think my biggest challenge developing my leadership skills was actually understanding that there are parallels with breaking bad news to patients and families. That to be an effective leader, if you have a good, diverse team around you, you will not please everybody all the time. And there are some things that you have to do because your organisation has said that that is what needs to happen, that people may not agree with. So I've had to learn how to manage conflict, how to recognise that conflict actually sometimes is good, because actually it's, if you manage conflict effectively, you can demonstrate listening skills and you can come to a very creative and usually much better outcome. But I've had to learn how to feel comfortable with conflict and how to manage conflict. And that toolkit of styles, it's not one style that does everything. Sometimes you have to be transactional. At the start of PPE for COVID, the rules say we have to do this now. But what I hope is that my general style, which is much more transformational and democratic, that's my default. And so just occasionally, if I have to say, we need to do this now, people will forgive me and people will come along with me because they will have understood that that's what's needed to do. That's my kind of, in a nutshell, for the moment. But let me hand over to Dr. Priya for your insights and your thoughts.
Okay, so some part of question from Seema I missed, but I think it is all about our leadership journey and what makes us feel good and the challenges. Yeah. So I think if I have to tell about my leadership journey, I think as I assess myself, I am a team player, but I am not a leader material by myself. So when leadership responsibility came on me suddenly, I was thoroughly confused. I didn't want to disturb any of my team members. At the same time, I was responsible for end results. So I wanted to deliver best with taking team together, and that was a difficult task without having any training in leadership development. Over the period when I learned to kind of compartmentalize my roles about me as a person and me as a leader or as a medical director then, and then who reports to whom. I mean, not necessarily you like to have that hierarchy when you're colleagues and friends initially. But at the end of the day, we have to be responsible for giving best possible care to our patients and families. As Fiona said, then from trying to be nice to everyone, I had to make shift to a position where I had to be little curt and say, no, whatever you think, I am saying that we will do this. You have to see your colleagues not being happy with you, but at the same time, maybe patients and families are satisfied. And then you have to decide for yourself whether it is worth doing that. Of course, then later on, by training, you learn to get into that role. But I think still the challenge, the most important challenge I feel, is to manage people in your team. Because unless you know them and you are interested in them and understanding them as persons who are working for your common goal, you won't work better. But if you're involved in them, there is a high chance that you want to give them some concessions as a person. At the same time, you want the task done. And I think making this detached attachment to your team members is something very challenging at times. I'll stop here. Thanks.
Very well said, Dr. Priya and Dr. Fiona. For a leader, it is very difficult to handle the team, especially that whenever the conflict arises. Can you just give a one important point for a leader to handle this conflict, especially the healthcare professional? That's much more.
Top tips.
I think that's really interesting. And I think listening. I think as a leader, you need to be able to very quickly understand the need to be objective. You can't be partisan. You can't favour one person's view over another, or a patient and a family conflict. You can't side with one person or one faction. So you can't. So you need to be calm. You need to be objective, and you need to listen. And it's that listening and understanding that actually the outcome of the conflict may be agreeing to disagree. But I think that trying to be calm and be objective and to not take sides. And the final thing is just understanding in that day's work or that morning's work, if suddenly conflict arises, it's also about being able to quickly think, what else was I going to do this afternoon, this morning in this clinic? Do I need to sort this out now? Very often, yes. Or actually, do I need to postpone it for a couple of hours so that everybody calms down, which might get a better outcome? But it's about thinking, while I'm sorting this out, all those other things on my to-do list, who's going to do those? Was I about to go out and see a patient? What's going to happen to that patient? So I think as a leader managing conflict, you, as well as objectivity, listening, you need to be agile. Your brain needs to let go of one version of your day and pick up another completely different version of your day. But just being assured, conflict is not always bad. but it's about how you can manage it. That would be my view. But Priya, what's your experience?
Yeah, one thing what you said, Fiona, is listening is most important, and I'll go one step ahead in saying why someone is saying what they are saying. You know, understanding that why. For example, if the child is on the ward and then somebody, social worker, is more with the mother and she comes with a view and a doctor is saying another, he might be just hierarchical, whereas social worker must have spent more time with mother, and they might have. So understanding, listening, and what is the thought process behind that thought process, I think that requires and helps in managing conflicts. Thank you.
I think if I can just come in there, Priya, you're absolutely right. There's always a reason, isn't there? There is always a reason. And in palliative care, very often is compassion and a fiercely protective love, respect, whatever it is for the person or for the healthcare professional. But 9.5 times out of 10, something will drive that conflict and anger. And by listening, usually it will present itself. It will become clear. But there's nearly always something at the heart of it.
Thank you so much, Dr. Fiona and Dr. Priyadarshini. It's a wonderful session we had, and I think we are working in a palliative care since so long, and listening to all of you is very, very great. And thank you. Now we are overshooting for 2 minutes, so we like to close this session. Thank you so much, and thank you organizing committee to giving us opportunity to be in the part of this August gathering. Thank you so much, Dr. Anjum and team. Thank you very much.
Thank you.
Thank you.
Thank you, Priya ma'am, Fiona ma'am. Thank you so much.
Thank you.